For decades, millions of older adults have been taught something that sounds like an absolute truth. The ideal blood pressure is 120/80. Doctors say it, medical textbooks repeat it, the media reinforces it again and again. And many people have believed that as long as their blood pressure reaches this perfect number, they will be safe, live longer, and avoid stroke and heart disease. But what if I told you that for people over the age of 65, a blood pressure of 120/80 could actually be the beginning of a tragedy? What if lowering blood pressure too much doesn't help you live longer, but instead causes dizziness, falls, broken bones, physical decline, and even death? Would you still trust that number without question? The truth is, the aging body does not function the same way as a younger one. Blood vessels become stiffer, reflexes slow down, and the body's ability to adapt weakens. In that context, forcing blood pressure down to levels considered ideal for younger adults can become a dangerous mistake. In this video, you'll learn why 120/80 is not always better, what blood pressure range is actually safer for older adults, and most importantly, how to avoid the silent but extremely dangerous risks that many seniors are facing without realizing it. 120/80 is not always ideal for older adults. For many years, the number 120/80 has become an almost absolute standard in medicine. People have been taught to believe that the closer their blood pressure is to this level, the safer they are, the longer they will live, and the more protected they will be from stroke and heart disease. For younger adults, this is largely true. But for older adults, especially those over the age of 65, and particularly over 75, this belief can become a dangerous trap. The problem is that the aging body does not function the same way as a younger one. As we age, blood vessels lose their elasticity and become stiffer. They respond more slowly to changes in posture, such as standing up, sitting down, or getting out of bed. Blood pressure, however, is the key force that delivers blood and oxygen to the brain. When blood pressure is lowered too much, the brain is often the first organ to suffer. This is why many older adults, after being treated to reach a blood pressure of 120/80, begin to experience symptoms that seem normal or harmless. Mild dizziness when standing, brief lightheadedness, shortness of breath, fatigue, or mental sluggishness. Many assume this is simply part of aging. In reality, these symptoms are often signs that blood pressure has fallen below a level the body can safely tolerate. More dangerously, these episodes of dizziness do not stop at discomfort. For older adults, a single loss of balance can change an entire life. A fall in the bathroom, a slip when getting out of bed at night, or a moment of unsteadiness outdoors can lead to hip fractures, wrist fractures, or head injuries. What was once an independent life can quickly turn into months of hospitalization, surgery, and rehabilitation, and in many cases, independence is never fully regained. Lowering blood pressure too much also has serious effects on the kidneys and the brain. The kidneys require a certain level of blood pressure to filter waste effectively. When pressure is pushed too low, especially in older adults whose kidney function is already declining, the risk of acute kidney injury or progressive kidney failure increases significantly. In the brain, even mild but prolonged reductions in blood flow can impair concentration, memory, and over time may worsen the risk of cognitive decline and dementia. What is most concerning is that many deaths in older adults do not begin with a stroke or heart attack, but with a silent chain of events: low blood pressure, dizziness, falls, fractures, prolonged immobility, pneumonia, physical decline, death. And at the root of this cascade, in many cases, lies overly aggressive blood pressure lowering. This does not mean that older adults should ignore blood pressure control. High blood pressure remains dangerous. But the critical message is this: lower does not always mean better. For people over 65, the goal should not be a perfect number on paper, but a blood pressure level that safely supports brain function, protects the kidneys, and most importantly, allows them to stand, move, think clearly, and live independently. 120/80 may be ideal for younger adults. But for older adults, that number is sometimes not a goal. It is a dangerous threshold that must be carefully reevaluated. New research reveals a safer sweet spot for older adults. In medicine, few things are more disruptive than a large, well-designed study that forces us to reconsider standards that have been trusted for decades. And that is exactly what has happened with newly published data in the Journal of the American Medical Association, one of the most respected medical journals in the world. This research does not merely raise questions, it directly challenges the long-held belief that lower blood pressure is always better for older adults. Unlike many earlier studies that focused primarily on healthy, middle-aged individuals, this analysis followed tens of thousands of adults over the age of 75 in real-world conditions. The participants were not idealized subjects. They included people who were robust and frail, individuals with diabetes, cardiovascular disease, and kidney impairment, as well as those taking multiple medications simultaneously. Because of this, the findings reflect true clinical reality, not a carefully filtered laboratory population. What the researchers discovered was striking even to them. When mortality rates, cardiovascular events, and overall quality of life were compared, adults over 75 with an average systolic blood pressure between 130 and 140 mmHg lived longer and remained more stable than those in other blood pressure ranges. This range represents a physiological sweet spot, low enough to reduce the risk of stroke and heart attack, yet high enough to maintain adequate blood flow to the brain, kidneys, and other vital organs. In contrast, the group with systolic blood pressure below 120 mmHg long, considered the gold standard, showed a troubling pattern. Rates of falls, fainting, acute kidney injury, and overall mortality were significantly higher. From a geriatric physiology perspective, this finding is not surprising. At advanced ages, arteries become stiff and the body's ability to regulate blood pressure becomes less flexible. When blood pressure is lowered too aggressively, the body loses its margin of safety, especially during posture changes or mild dehydration. The brain and kidneys organs most sensitive to reduced blood flow are the first to suffer. At the opposite extreme, the study also confirmed that systolic blood pressure above 150 mmHg is not safe. This group experienced a clear increase in the risk of stroke and myocardial infarction, driven by sustained vascular damage, accelerated atherosclerosis, and increased clot formation. These findings reinforce an essential point. While blood pressure should not be lowered too much in older adults, allowing it to remain excessively high is equally dangerous. The true importance of this research does not lie in assigning a rigid number, but in shifting the clinical mindset. Rather than asking, how can we bring everyone to the same blood pressure target, the more appropriate question becomes, which blood pressure range leads to longer life, fewer complications, and better quality of life for each age group? For adults over 75, the data clearly indicate that the answer lies in the 130-140 mmHg range, not 120. From a professional standpoint, this serves as a critical reminder that medicine is not a race to push numbers lower, but an exercise in balancing benefits and risks. In older adults, the long-term theoretical benefits of aggressive blood pressure reduction may be outweighed by immediate dangers: falls, kidney injury, and cognitive decline. The 130-140 sweet spot is not a weak compromise. It is a decision grounded in strong scientific evidence and a deep understanding of the aging physiology. In other words, this research does not encourage complacency about blood pressure. Instead, it establishes a new clinical truth. For older adults, safety lies in moderation, not in extremes that are too low or too high. Why older adults are physiologically different, and why the same blood pressure number means something very different. One of the biggest mistakes in caring for older adults is treating the aging body as simply an older version of a younger one. In reality, once people reach their 60s, 70s, and 80s, the body does not merely become weaker, it begins to operate according to fundamentally different physiological rules. Blood pressure is one of the areas where this difference becomes especially clear. The first and most important difference is that blood vessels become stiffer over time. In younger individuals, blood vessel walls are soft and elastic, able to expand and contract smoothly with each heartbeat. When the heart pumps, these flexible vessels absorb pressure and help deliver blood efficiently to the brain. In older adults, however, blood vessels have endured decades of constant pressure. Calcium deposits and atherosclerotic plaques accumulate, causing the vessel walls to lose elasticity and become rigid. When blood vessels are stiff, the same blood pressure delivers less blood to the brain than it would in a younger person. In other words, 120/80 may be sufficient for a young adult, but 120/80 may be inadequate for an older adult. The brain, an organ with very high oxygen demands, is often the first to sense this shortfall, manifesting as lightheadedness, dizziness, fatigue, or mental slowing. The second key difference lies in the body's blood pressure regulation reflex, the automatic system that stabilizes circulation when posture changes. In younger people, standing up triggers an almost immediate response. Heart rate increases slightly, blood vessels constrict appropriately, and blood pressure remains stable. Blood flow to the brain is preserved, often without the person noticing any change at all. In older adults, this reflex becomes slower and less precise. The pressure sensors in blood vessels lose sensitivity, signals reach the brain more slowly, and corrective responses are delayed. As a result, when an older person stands up, blood pressure may drop before the body has time to compensate, temporarily reducing blood flow to the brain. If baseline blood pressure is already low, this effect becomes more pronounced and more dangerous. This explains why many older adults experience dizziness, lightheadedness, or brief visual blackout upon standing even when their seated or lying blood pressure appears perfect. The third difference, often underestimated, is how the aging body processes medications. In younger adults, the liver and kidneys function efficiently, allowing drugs to be metabolized and eliminated relatively quickly. With aging, liver and kidney function gradually decline, often without obvious symptoms. As a result, medications, especially blood pressure-lowering drugs, remain in the body longer and exert stronger effects than intended. A dose that is entirely appropriate for a 50-year-old may become a physiological overdose for an 80-year-old, even when the prescription itself is technically correct. This can lead to excessive blood pressure lowering, particularly at night or during posture changes. Such effects are a common cause of orthostatic hypotension, fainting, and falls in older adults. Because of these three fundamental physiological changes, stiffer blood vessels, slower regulatory reflexes, and increased medication sensitivity, older adults often require slightly higher blood pressure levels than younger people to remain safe. The goal is not to match someone else's numbers, but to maintain adequate blood flow to the brain, prevent dizziness when standing, enable confident movement, and preserve independence. Understanding these physiological differences is the foundation for recognizing a critical truth. Applying the same blood pressure target to all ages is not scientific, it is a dangerous oversimplification. For older adults, blood pressure is not just a number. It is a delicate boundary between stability and serious harm. Orthostatic hypotension, the most dangerous, yet often overlooked warning sign in older adults. Among all blood pressure-related issues in older adults, orthostatic hypotension, the dizziness or lightheadedness that occurs when standing up, is the most dangerous warning sign, yet paradoxically, the most frequently ignored. Many people dismiss it as just getting older, standing up too quickly, lack of sleep, or general weakness. But in geriatric medicine, this symptom is a red flag, signaling that the body is no longer able to maintain safe blood pressure when changing posture. From a clinical standpoint, orthostatic hypotension is clearly defined. If upon standing, systolic blood pressure, the top number, drops by more than 20 mmol, or quaching diastolic blood pressure, the bottom number, drops by more than 10 mmol. This is no longer a normal physiological response, but a high-risk medical condition. What makes it particularly dangerous is that it can occur even when blood pressure measured while lying down or sitting appears perfect. Imagine an older adult whose seated blood pressure is 130/80, a number that reassures both patient and physician. Yet when that person stands up, blood pressure falls to 105/65, or even 95/60. Within seconds, the brain receives insufficient blood flow. Vision blurs, the head spins, coordination falters. In that brief moment of imbalance, a serious fall can occur. For a younger person, a fall may result in nothing more than a bruise. For an older adult, however, a fall can be the beginning of a rapid and devastating decline. Hip fractures, femur fractures, and head injuries carry extremely high rates of disability and mortality in the elderly. Studies show that 20 to 30% of older adults die within 1 year after a hip fracture, not from the fracture itself, but from subsequent complications such as prolonged immobility, infection, pneumonia, and physical deconditioning. What makes orthostatic hypotension especially dangerous is that it does not always cause immediate fainting. Most of the time, it presents with vague, subtle symptoms, a brief sense of lightheadedness, needing to hold onto a wall, or standing still for a few seconds before feeling safe enough to walk. Because these symptoms feel mild, many people tolerate them for months or years. Yet with every episode, the risk of falling silently accumulates. The underlying cause of orthostatic hypotension in older adults is often overly aggressive blood pressure lowering, particularly due to medications. When baseline blood pressure is already low, the body no longer has enough physiological buffer to compensate upon standing. Stiff blood vessels, slowed reflexes, and prolonged drug effects combine to cause a sharp drop in blood pressure before the nervous system can respond. A critical concept that many people fail to understand is this: orthostatic hypotension is more dangerous than mildly elevated blood pressure. A 75-year-old with a blood pressure of 140/85 who stands up without dizziness, walks steadily, and lives independently is far safer than someone with a perfect blood pressure of 120/75 who becomes lightheaded every time they stand. In geriatric medicine, the ability to stand and walk safely matters far more than achieving an ideal number on a monitor. For this reason, evaluating blood pressure in older adults must go beyond asking, "What is your blood pressure?" The more important questions are, do you feel dizzy when you stand up? Does your blood pressure drop significantly when you change position? If the answer is yes, then treatment must be reconsidered, no matter how ideal the seated or lying blood pressure appears. For older adults, a number that looks right but leads to falls is ultimately the wrong number. Recognizing and detecting orthostatic hypotension early is one of the most powerful tools we have to prevent falls, preserve independence, and truly extend healthy lifespan in older adults. Every older adult needs an individualized blood pressure target. There is no one number for everyone. One of the most important advances in modern medicine, especially in geriatric care, is a fundamental shift in mindset, moving away from rigid, formula-based treatment toward individualized care. This principle is particularly critical when managing blood pressure in older adults. After the ages of 65, 75, or 85, the differences between individuals often become far greater than the differences between the numbers on a blood pressure monitor. In reality, not all older adults are the same. Some people in their 70s walk daily, remain mentally sharp, and have no significant medical conditions. Others of the same age may be frail, burdened with multiple chronic illnesses, and at high risk of falling. For this reason, applying a single rigid blood pressure target to everyone is a dangerous mistake. For adults aged 65 to 75 who are relatively healthy with no diabetes, no significant cardiovascular disease, and no kidney failure, this group represents a transitional phase between middle age and older adulthood. In these individuals, a systolic blood pressure of approximately 130-140 mmHg and a diastolic pressure of 70-85 mmHg is generally appropriate. This range is low enough to protect the heart and blood vessels, yet high enough to ensure adequate blood flow to the brain and reduce the risk of dizziness when standing. Some individuals in this group may tolerate lower pressures, but only if they are completely symptom-free and do not experience orthostatic hypotension. In the 75-85 age group, physiological changes become more pronounced. Blood vessels stiffen further, blood pressure regulation slows, and tolerance to medications declines. For these individuals, a safer target is often 135 via 145, 70, 85 mmHg. This range represents a balance reducing the risk of stroke from excessively high blood pressure without pushing the body into cerebral hypoperfusion during standing or walking. At this stage of life, the priority is no longer preventing disease decades into the future, but preventing falls, preserving mental clarity, and maintaining independence right now. For adults over 85 years old, or for those who are frail and prone to falls, treatment goals must be even more conservative. In this group, blood pressure levels of 140, 150, 70, 85 mmHg are often acceptable and may actually be safer. While these numbers may appear high on paper, It is essential to understand that at very advanced ages, mortality risk more often stems from falls, fractures, prolonged immobility, and their complications, rather than from moderately elevated blood pressure. An 88-year-old with a blood pressure of 145/80 who walks steadily, feels well, and sleeps and eats normally represents a successful treatment outcome, not a failure. The most complex cases involve older adults with chronic conditions such as diabetes, cardiovascular disease, prior stroke, or chronic kidney disease. In these individuals, high blood pressure increases cardiovascular risk, but overly aggressive lowering can lead to kidney injury, dizziness, and falls. As a result, targets typically fall within the 130–140 mmHg range, but must be carefully individualized. Clinicians must look beyond the numbers, closely monitoring symptoms, kidney function, orthostatic blood pressure changes, and daily quality of life. The most important point to emphasize is this: the ideal blood pressure target is not the most impressive number, it is the most appropriate one. A textbook perfect blood pressure that leaves an older adult exhausted, fearful of standing, afraid to walk, and living in constant anxiety is not good treatment. In contrast, a slightly higher blood pressure that allows safe movement, mental clarity, and independent living represents true therapeutic success. For older adults, the right question is not, does my blood pressure meet the standard guideline? But rather, is this blood pressure appropriate for my age, physical condition, and daily life? Understanding this distinction is the key to moving beyond mechanical, number-driven treatment and toward a more humane, safer, and genuinely beneficial approach to caring for older adults. Treatment must focus on the person, not the number. When medicine is no longer a race for perfect readings. In modern medicine, especially in the care of older adults, there is a principle that is increasingly emphasized but still not fully applied in real-world practice. Treatment must focus on the person, not just the number on a monitor. This principle may sound simple, but misunderstanding or ignoring it can lead to very serious consequences. For younger adults, aiming for ideal numbers often makes sense, but for older adults, blood pressure numbers are no longer the ultimate goal. What matters far more is this: can the person stand up steadily? Do they feel dizzy, lightheaded, or afraid of falling? Are they still mentally clear, independent, and able to care for themselves? Because for older adults, one fall can cost them the rest of their life. Clinical experience shows that many cases labeled as successful treatment on paper blood pressure at target, clean lab results, guideline-compliant prescriptions tell a very different story in real life. Outside the chart, patients feel exhausted, sluggish, mentally slow, afraid to stand, afraid to walk. They begin to sit more, lie down more, and move less. And from there, a predictable downward spiral begins: muscle weakness, loss of balance, falls, fractures, prolonged immobility, infections, physical decline. In this context, a blood pressure number that looks perfect on paper no longer represents protection, but may instead signal that treatment is targeting the wrong goal. Proper treatment for older adults does not mean forcing their bodies into standards designed for younger people. It means preserving their ability to live their own lives. For most seniors, two priorities must always come first. First, preventing falls. A fall in an older adult is not a minor accident. It is a serious medical event that can lead to indirect death within months or a year. Therefore, if a treatment plan causes frequent dizziness upon standing, requires the patient to hold on to walls, or forces them to pause for several seconds before walking, then no matter how good the blood pressure looks, that treatment plan must be reevaluated. Second, preserving mental clarity, independence, and quality of life. Older adults do not just need to live longer, they need to live well. They need a clear mind to converse, read, remember their loved ones. They need enough physical strength to walk, bathe, and go outside independently. Any treatment that leaves them lethargic, confused, or stripped of motivation is a failed treatment, even if the medical record says blood pressure well controlled. In geriatric medicine, there is a crucial concept: treat the patient, not the number. This means clinicians must look at the whole person: their age, physical condition, mobility, fall risk, medication tolerance, and personal goals. An 80-year-old who walks confidently with a blood pressure of 145/85 may be far safer than someone with a perfect 120/75 who becomes dizzy every time they stand. The greatest failure in treating blood pressure in older adults is not a slightly elevated number, but causing the patient to lose confidence in movement, lose independence, and lose joy in daily life. When an older person begins to say, "I'm afraid to stand up," or "I'm afraid to go outside," this is no longer a psychological issue, it is the consequence of an inappropriate treatment strategy. True treatment for older adults means finding the blood pressure level at which they feel most stable, most safe, and able to live well, not the level that looks best in a textbook. This is the line between mechanical medicine and humane medicine. And for older adults, humane care is safe care. If you've followed this far, remember this one essential truth. Blood pressure is not a race for numbers. It is a journey to protect safety and quality of life in older adults. 120/80 is not always right. Lower is not always better. And a number that looks good but causes dizziness, fatigue, fear of standing, or fear of walking is never a successful treatment. What matters most for older adults is the ability to stand steadily, think clearly, live independently, and enjoy daily life. Once you understand this, you are freed from rigid numbers and better able to listen to your body and have more meaningful conversations with your doctor. If you or a loved one over 65 is being treated for blood pressure, review what has been shared in this video. Pay close attention to dizziness when standing. Prioritize safety over chasing numerical targets. The right knowledge can prevent a fall, and sometimes it can save a life. If you found this content helpful, please subscribe to the channel and turn on notifications so you don't miss future videos. We will continue sharing up-to-date, clear, and truly practical medical information for older adults, the kind of information that is often not fully explained in the clinic. Please share this video with your parents, relatives, and friends over 65. Knowing a little earlier can prevent a major tragedy. Thank you for watching until the end, and we'll see you in the next video.